Hello, everyone. We're going to get started with the webinar. Thank you for joining us. It's Kathleen O'Neill-Smith. I'm in Boston, and I'm a board member at the International Peptide Society, and we're going to get started just with a little bit of information, a primer on cerebrolysin. So I'm assuming that many of you were not at the Dana Point where we just had our gathering, so I'll just go through cerebrolysin from that perspective. I'm an internal medicine doctor, and I use a lot of cerebrolysin in my practice, and we'll talk about that as we go through. Cerebrolysin is a combination of nerve growth factors, and these nerve growth factors are really effective for the repair and recovery of both central nerve cells within the brain and peripheral nerve cells. These nerve factors are isolated from porcine brain matter, and they're used in many countries around the world, and they've been used for years, and they have been used in many research forums for Alzheimer's, Parkinson's, MS, TBI, etc. So in Europe, cerebrolysin is approved for use, and in Asia for post-stroke treatment. So let's continue. Let's see. Oh, so cerebrolysin is in the category of a nootropic, and it's synthetic, as I just described to you. It's neuroprotective. It's neuroregenerative. It has these neurotrophic pulling in the growth factors to repair if there's an injury to the brain, similar to BDNF and other nerve growth factors. It has a low molecular weight and can cross the blood-brain barrier and the blood CSF. So it's very easily accessed, has very good access to the nervous system. It is very synaptoblastic, improving synapse function, and kind of can counter synaptoclastic activity. And in doing this, it improves the neuron-to-neuron communication and can also, in the same effective way, reduce amyloid deposition. So in decreasing amyloid deposition, it does this by multiple mechanisms, but is also accompanied by a reduction in the microgliosis that happens around the vasculature, and a reduction in the astrogliosis, and increased expression of different markers of vascular fitness, and that's CD31 and ZO-1. So cerebrolysin can reduce the levels of phosphorylated amyloid precursor, the APP, and the accumulation of this amyloid precursor protein in the neurons. It also increases the expression of the blood-brain barrier GLUT1 via mRNA stabilization, and allows for the increased uptake of the type of glucose, which is the essential brain nutrient, and basically effectively utilizing glucose within the brain so that it's not toxic to the central nervous system. So I use cerebrolysin in a lot of different ways. I've used it in, we'll talk about this in a minute more. I'll give you a couple case studies in traumatic brain injury and ocular migraines that may be due to immune dysregulation. I haven't used it a lot in Alzheimer's because I don't have a lot of Alzheimer's patients in my practice, but I have used it for memory impairment, mild cognitive impairment, and with great success. So it works on the glutamate receptor as well, and helps the integrity of the receptor, which we all know is really glutamate, and its actions are really crucial for the learning process. So cerebrolysin increases the GLUT-R1 density in the regions of the hippocampus in a very significant way, improving learning and memory. Reductions of this GLUT-R1 receptor in the hippocampus with patients with Alzheimer's is very significant and can result in this synapse lack of communication, and is related and associated with neurodegenerative disease, particularly cognitive disorders. So as we said, it has a regulatory effect on energy metabolism, and it's a neurotropic stimulation. And in these studies, there have been no adverse effects recorded And the beneficial effects can persist even 12 weeks after discontinuing treatment. And in my use of cerebrolysin in my practice for the ocular migraines and traumatic brain injury, I get a continued sustained benefit for quite some time. It varies depending upon the use in the patients that I'm using it in. When I think of disease or when I think of any process, symptoms, or disease in my patients, I'm thinking, is this an immune system issue where I need to modulate the immune system? Is this a free radical issue where I need to reduce the generation of free radicals and the oxidative stress? Is this an inflammatory issue that can be related to a number of things? So cerebrolysin clinically will work to protect the neurons from free radical stress and oxidative stress, and also improve the utilization and the movement of lactic and keto acids and the neurotoxic effects of glutamates. It improves the metabolic activity, the glucose upregulation within the central nervous system, as we mentioned earlier. And in doing, working on the GLUT-R1 receptor, it also enhances cognitive function, memory, motivation, and creativity. And these are a lot of the therapeutic uses: the concussion, the CTE, traumatic brain injury, dementia, mild cognitive impairment, stroke, post-stroke rehab, transient ischemic attack, and also mood dysregulation. So just to kind of go through a couple case studies, in patients with concussion and TBI, so concussion could be mild with nothing on exam in terms of diagnostic studies. The MRI could be entirely normal, everything entirely normal, but we know that the patient has had a concussion. And in TBI could be severe, where you might have, 5 cerebral hemorrhagic bleeds. I've used it in both cases. And in both of those cases, usually young people in their 20s with concussion and TBI, both of those cases using cerebrolysin IM and IV. So depending upon the patient, I may use it different ways. I've had tremendous benefit with reduction of the oxidative stress and clearing of the brain. It's had a remarkable benefit. We can talk more about that in details in the IPS meetings. I've also used it in a patient who came in complaining of cognitive impairment. And this was a gentleman, 49-50, who had some reflux, had gone to his primary care doctor, and the primary care doctor had put him on PPIs. And he had a cytochrome P450 variant which caused him to not break down the PPI very well, and an E3, E4 in terms of his genomics, and he had significant cognitive impairment. When he came to see me, he and his wife both told me that his memory was markedly impaired. And I gave him cerebrolysin IM, several cc's, and essentially his cognitive impairment, noted both by him subjectively and objectively by his wife from observation, were dramatically impaired. And the effects lasted quite some time. So it's a wonderful option even within your office to use as a therapeutic trial, which is just a trial of therapy when someone comes in and complains of a cognitive impairment, to see what are the benefits. And I really expect a benefit with an injection of 2 to 4 cc's to occur within hours to days. And this gentleman's benefits were within hours. And I checked in with him the next day, and both he and his wife were on the phone, and they both were quite amazed, and he wanted to, basically invest in the company that made this stuff. So for him, he was taken off the PPI for this particular patient, and understood that the ramifications of that. We had other lab work pending, and we're obviously going to improve other markers, biomarkers of oxidative stress, but the cerebrolysin was the mainstay that basically helped him to understand that he could improve this cognitive impairment pretty readily, and that the oxidative stress, he's a savvy guy, was a component of it. I've had a patient who was post-stroke, post-stroke, who is a professor at Dartmouth, who not that long ago, within the last 2 months, had gone to the ER in the acute setting of having a stroke, received cerebrolysin, and abated the stroke. He came to see me after the stroke. He's an older gentleman, an older professor, and he has been working with me for some time, and he said, I wanted you to know I had this event, and I wanted to know, what do I need to do to clean it up? And we had cleaned up a bunch of things before for him from an inflammation perspective and also from an oxidative stress perspective. So his wife was with him as well, and basically we prescribed cerebrolysin, and I basically gave him a weekly dose IM that his wife was going to administer of cerebrolysin to take, and I've spoken to him recently, and he's doing remarkably well. He feels better than ever. We just wanted to clean up the after effects of what happened during his ischemic stroke and all of the reactive oxygen free radical species that accumulated. He proactively, preemptively cleaned those up with a 1 time a week times 3 weeks treatment with cerebrolysin. And the final case, based on these therapeutic uses here, is that I had a gentleman with severe depression who had been treated with multiple different meds, and his etiology of depression was multifactorial. And, we were treating, he had never been treated with B12, he had never been treated with some very, very basic things, and we added those things, but we also did cerebrolysin early in the course, and he had tremendous benefit and re-regulation of mood, euthymia, with cerebrolysin. In a case like this gentleman who had a multifactorial mood dysregulation, he also needed other things like the B12, like some thymosins, which you may or may not know about, but if you join the society, you'll learn about them in great detail. So there are many ways to vary the signal when you want to improve memory and learning, and cerebrolysin is just one of those components that it can have tremendous benefit. The primary time that I would think about using cerebrolysin is when I'm really confident that there's likely to be free radicals or reactive oxygen species. Then I'm definitely likely to go to the cerebrolysin quite quickly, at least as a therapeutic trial, but certainly open to what benefits the patient receives and what they report back to me. So in dementia, cerebrolysin can decrease beta amyloid deposition. It can decrease the tau protein phosphorylation. And again, it's synaptoblastic, increase in synaptic density. Restores the neuronal architecture, results in improved cognitive and behavioral performance. And I always consider it when someone has an ApoE E4, whether it's a 1 variant or a double variant of E4. Looking at a meta-analysis of the efficacy of cerebrolysin for Alzheimer's, again, going back to the studies that we looked at before, it's very effective with senile dementia, although I don't have personal experience with that in multiple studies. And amelioration of the amyloidosis, this is in a rat model, will basically show that cerebrolysin will induce synaptoblastic activity and neurotrophic activity. We also already heard about the amplification of the blood-brain barrier GLUT1 glucose transporter gene to deliver the optimum sugar to the brain to assist in brain-derived peptide formation. An infusion with Cerebro for 4 weeks, this is a high dose. I've never used a dose quite this high, of 30 ml cerebrolysin daily on 5 consecutive days. I did use 5 ml daily on the traumatic brain injury boy on consecutive days because I really wanted to get an effect. He had 5 intracerebral bleeds. And here we can see, and this was the basis of my doing that because it led to a significant improvement in their situation clinically. Rapid efficacy, which I did experience. So the dosing is typically 1 cc. You can do it IM. I usually do it IM. I have not done sub-Q cerebrolysin. You can do it daily if you're doing low dose, like I might have done that in the gentleman who had the mild cognitive impairment from the PPI. But I wanted to get a benefit, so I did 2 cc's for him. So you could do QD every day for 7 days, and you could do it in cycles, 7 days, 7 days off, 4-week cycles. You can do it in a variety of ways, or you can give a 5 cc IV drip in consecutive days, depending upon the severity of the injury, or 1 or 2 times a week. For the traumatic brain injury young man, after doing the daily cerebrolysin, I basically went down to 1 time a week for several weeks to continue the cleanup of the brain because I was doing multiple other peptides at the same time. So hopefully this is helpful in an introduction to cerebrolysin. You'll learn a lot more about how we can use this in other situations, ocular migraines, etc., and in the conferences. I'm open to taking any questions that you have. Thank you.
Hi, thank you so much for hosting our webinar, Kathleen. This was very informative. We don't yet have any questions. I'm waiting for some more to come through the question panel.
Great.
So those attendees that are joining us tonight, if you have any questions, go ahead and post them. To the right side of your screen, you'll see the Q&A section. Just post them right there, and we will read them off. And we'll go ahead and give you a couple seconds to do that.
All of these peptides are new to all of us, and learning about how to utilize them is really one of the things that we at the IPS are hoping to share with you. So we are using them regularly. I use them every day in my practice, and I know that there's really no downside, and so I'm open to what the upside is. So I've been using them for at least 4 years, in an attempt to heal people and to try to really improve the functioning of the nervous system, both centrally and peripherally, and it's just been wonderful. So if you are a member of the IPS and are going to join us at our conferences, we'll continue to give you case studies and share those with you with respect to the protocols that we've utilized. And then if you are a member of the IPS and you're on the website, I know that if you post questions online, we're happy to help you. So you don't have to have your questions tonight. You may have a case that comes up at a later point in time, and you might post that if you're a member of the IPS on the website, and we're happy to help you with that.
Yes, exactly. So we have questions that we can get to right now, but if we don't get to your question, go ahead and take it to the forum, and we can continue discussion there. But yeah, we'll go ahead and get started with this first question. What about daily use for prevention?
Well, I don't know how you're going to achieve that. First of all, cerebrolysin often it's an IM dose. There aren't a lot of people that are going to be able to afford to take a 1 cc IM dose long standing. The man with the depression, he was definitely high net worth, but he thought, he couldn't continue this sustainably from a financial perspective, long-standing. So we found ways to kind of get him a little bit over time. And I'm not really sure. I don't know why somebody would. We need to be cleaning up other things for the patient and looking at a variety of biomarkers rather than relying on one particular peptide or any one particular treatment plan, because these things are multifactorial. So I wouldn't rely on cerebrolysin alone for sugar delivery to the brain appropriately, for glutamate reduction. I just think that's not the best approach for keeping somebody well. But I would use it intermittently, one time a week or whatever you think may work for your patient, depending upon the indication that you're choosing it for.
Sorry, next question. Thank you very much. How is this dosed with IV? Is it added to NS?
Is it added to what?
NS.
Oh, normal saline, You can add it to NS. You can add it to sterile water. You could add it to, you can do it either way. So I don't think there's really no worry. You can add it. I've actually done Myers or glutathione pushes, like a 30 cc push. And during the push, I will also add in some cerebrolysin. So I've done it both ways. I don't think that you have to be worried about the particular solution that you're adding it in.
All right. Next question. Can cerebrolysin be used for ADHD?
That's a good question. I have not used it for ADHD, but I would, I really welcome that. ADHD patients are semi-complicated. Oftentimes they are on multiple medications. I always think it's polypharmacy when you start an ADHD medication because people end up needing, the majority of people I see who I don't particularly start on ADHD medicines but may come in on them, they often take lorazepam or benzo at night to come down, or they have CBD, usually pot or marijuana, maybe medical marijuana. So the issue with that is that you've got polypharmacy as far as I'm concerned, and cerebrolysin can do some cleanup, and I'm open to that. I haven't really used it extensively or, really ever in that because people are really, really wedded to their ADHD med and their benzo. But it's a great idea.
Thank you. And we're going to go ahead and do 2 more questions. And then, again, I highly suggest everyone taking their questions to the forum. Another question is it too late if a person had a stroke 3 months ago? Can cerebrolysin be still administered?
It's never too late. It's never too late. You can always clean up. I've had patients who had stroke like a year earlier, and I would give them cerebrolysin. Absolutely. Is it going to cure? You have to be careful what you offer them in terms of expectation. I would just say that we're dosing this to see, whether there is any, opening of the brain or awakening of the brain. I don't overpromise. I try to underpromise and overdeliver. So, but I would absolutely recommend cerebrolysin in post-stroke at any point, post-TBI at any point, post-concussion at any point. I think that there will be free radicals and reactive oxygen species at any point in post-stroke or post-TBI or post-concussion. I would absolutely offer cerebrolysin.
All right, and we're going to go ahead and do 1 more question. The last one, you mentioned use for PD in the beginning, but not later. How do you treat this? What is the cost?
What is, for what in the beginning?
You mentioned use for PD in the beginning, but not later.
What's
and then how do you treat this, and what is the cost?
I don't know what PDE is.
I'm not sure either. Care to elaborate, Dr. Schultz? All right. Parkinson's disease. There we go.
Parkinson's disease. Again, for Parkinson's, it would not be my primary or only treatment. It would be a component of the treatment. It's like glutathione can clean up reactive oxygen species, and we know that people who have Parkinson's can get dramatic effects, not all of them, but some of them with glutathione treatment. And cerebrolysin is similar. It's not the same. It works very, very differently. Glutathione is not a synaptoblastic and restoring communication and cell signaling between neurons, but certainly I would utilize cerebrolysin. It's going to depend. Like Parkinson's is a very complex disease, and I would say that understanding what the multifactorial etiologies are of your Parkinson patients and cleaning and looking up at a variety of biomarkers and thinking about how are you restoring the balance in those biomarkers, and then doing a trial with cerebrolysin. If I had a patient who had moderate Parkinson's, severe is going to be a whole different story, or advanced. If I had a patient who had moderate Parkinson's or mild Parkinson's, I would likely try it IV. I might do it IM if I had to, but I would likely do a 5 cc drip and see what the benefit was, ×1 as a therapeutic trial. Because I think you're going to get a benefit. You're going to know, whether there's something positive, not a complete reversal of anything, but something positive when you give a 5 cc. You're likely to experience some small shift depending upon the etiology of the issue. If you don't get a shift in some symptomatology, it doesn't mean that cerebrolysin isn't a good choice. It means that you may have other things that you need to clean up prior to adding the cerebrolysin. So I would certainly look at the whole biomarker panel, and I get many, many pieces of data before I would add cerebrolysin because I want the best effect from it. So like the patients that I've seen that I've used it on, I knew all of their biomarkers. I have 150 or 200 biomarkers in my repertoire that I'm looking at that if your B12 is 300, I'm not giving you cerebrolysin. If you need methylfolate, I'm not giving you cerebrolysin. If you have a glutamate level that is measured and it's extensively elevated, I'm not going to give you cerebrolysin right away. I'm going to try to clean up those other things before I add the cerebrolysin because I'm concerned that I'm not going to get the benefit I want, and I don't want my patients to associate no effect with something that can be remarkably beneficial for them. So this has to be looked at the context in terms of the patient, and if it's a new patient, I need data before I treat them. I'm not going to do a therapeutic trial even. If it's a patient that I know and I have multiple data points on them over time, and I'm a person who likes a lot of data points, and I at least like, my patients, I want 3 data points in time because 1 doesn't mean anything to me. 2 is very helpful, but if they're different, they're not so helpful. I like a 3 data point analysis, patterns of 3 to see what's going on for this person. Once I have those data points and I've normalized some of those or balanced some of those, then I'm going to probably try the cerebrolysin because I want the best effect